So hello everyone, a very warm welcome from Vienna, Austria. This is the fourth edition of the still brand new series on webinars of the EuroELSO organization. It's a very cold and misty day today in Vienna, and even if the weather was better, I couldn't think of anything else but discussing on mechanical ventilation during veno-venous ECMO today with our renowned expert, who is Matthieu Schmidt from Paris, France. Matthieu has a subtle experience in publishing papers on ECMO in terms of prognostication, and he also did very significant things on mechanical ventilation during ECMO. So it's a great pleasure to have you here, Matthieu. Before you start your presentation, just let me give our participants a couple of useful information. When you look at your webinar 2 at the panel that you have, you will be able to put in your questions at any time starting from now and even after the presentation of Matthieu's. I will take your questions and pass them on to Matthieu so we can have a lively discussion taking into account your questions after the presentation of Matthieu's. Now, if you have to run in between because your ICU is busy and you wouldn't be able to finish all the way through, don't worry about it. All sessions will be recorded and you will find them under www.euroelso.net/education, and alternatively you will be able to look for these contents in any search engine or on YouTube. So thank you once again for joining today's session, and Matthieu, this is you. Thank you for being here today.
So good afternoon everyone. I'm very happy, very glad to be there today to talk with you about mechanical ventilation on ECMO. So it's quite a new topic, happened since maybe 10 years ago, 10, 15 years ago. And it's a fascinating topic because it's moving a lot and we have so much research to do and so much questions still on. So as you know, if you ventilate your patient with 6 milliliters per kilogram ideal body weight, we have still some patient, we will have some tidal hyperinflation, and probably the sickest patient will have tidal hyperinflation despite using conventional ventilation with a low tidal volume. And this is expressed on that slide with CT scan slide, when you can see all the red spots corresponding to tidal hyperinflation. And this may occur even if the plateau pressure is well controlled, meaning if the plateau pressure is below 30, you may still see some hyperinflation over distension, and then you may generate some ventilator-induced lung injury. So probably for the sickest patient, 6 milliliters per kilogram ideal body weight is still too high. And we need to think about decreasing this potential risk of mechanical ventilation. And if you compare these patients, so the sickest one, with which we can call them the less protected patient, if you compare all the inflammatory marker in the bronchoalveolar lavage, you see that where even if they receive low tidal volume, they have still a very intense biotrauma on the bronchoalveolar lavage. So the first message is that probably the smaller the baby lung, the greater is the potential for unsafe mechanical ventilation. So this is typically all patients on ECMO, the sickest one. So there is a great potential for unsafe mechanical ventilation in these patients. So the key question of the day is how to treat the baby lung gently. And we have a couple of studies just before talking about ECMO, a few studies saying that maybe there is some indice to say that if you markedly decrease your plateau pressure much lower than 30 centimeters of water, which is commonly accepted, you may also decrease the mortality proportion, the mortality risk. In another study from UK, showing that there is maybe, again, some benefit to decrease the mean tidal volume much lower than 6 milliliters per kilogram. And This is a clinical question. When you got this kind of patient with, we have all seen this kind of patient, especially during the H1N1 pandemic, when you have the lungs of the patient, which are too stones, very difficult to ventilate. Or should I ventilate this kind of patient with this chest X-ray? So the principles of VV ECMO is, first of all, to replace pulmonary function. This is why you put your ECMO on. This is a visual things, but we don't have to forget that two other benefits of VV ECMO is to allow the lung to rest and to save time, to give time, to have time to allow healing of the lung and to be patient for waiting for the healing of the lung. So if we summarize what harms the respiratory system, what do we know actually? We know that there are a couple of ventilator-induced lung injuries. We have the atelic trauma, we have the volute trauma, which has been very well developed 15 years ago. We have the barrow trauma. We have a new concept of the biotrauma, meaning that all the inflammatory markers which are released in the circulation might impact the benefit as well. And the last one is a myotrauma. We will deal with patients who will be ventilated for weeks, even months. So we need to pay attention also to the myotrauma and the diaphragmatic induced injuries. So what should be the objectives of mechanical ventilation for patient ventilated on VV ECMO? We can say that probably we should target a mechanical ventilation with low pressure, low volume, and to try as possible to preserve diaphragm activity. Easy to say, but not so easy to do. But what you need to consider is that the degree to which ventilator settings can be reduced will depend in large part on the amount of ventilation and oxygenation achieved via the extracorporeal circuit. It means that to markedly reduce your mechanical ventilation, even to avoid using mechanical ventilation, you need to have high flow, and to get high flow, you need to have a large drainage cannula, because you know the Poisson law showing that there is a very strong relationship between the diameter of the cannula and the flow that you may get. So if you want to markedly reduce your mechanical ventilation, you need to target high ECMO flow to be sure that mechanical ventilation won't be an issue and mechanical ventilation won't be so useful for oxygenation and decarboxylation. So, you know this recent paper done by Luciano Gattinoni, which summarized the mechanical power of mechanical ventilation. And in this complex equation, you see that there are a couple of components. The first one, probably one of the most important one, is the tidal volume. You see that the impact of the tidal volume inside the mechanical power is quite huge. We have also the respiratory rate, which will impact the mechanical power. And lastly, we have the peep. So we need to play with these three settings in order to reduce the mechanical power of mechanical ventilation on ECMO. So one of the first messages is probably to say that we should reduce the plateau pressure on ECMO. And to illustrate that, we have this study done in 2009 where they ventilate 32 patients with IRDS net strategy, severe IRDS. And for 10 patients, the plateau pressure was at the upper limit acceptable, which is between 28 and 30 centimeters of water. And for these 10 patients, they did a bronchoalveolar lavage, they did a CT scan, and then for the protocol, they reduced the tidal volume to achieve a plateau pressure between 25 and 28. And to compensate the respiratory acidosis and to compensate the low pH induced by the tidal volume reduction, they had extracorporeal carbon dioxide removal for 72 hours. And then they redo bronchoalveolar lavage and CT scan. And then they could compare before and after tidal volume reduction and plateau pressure reduction. So what they show? They show that they were able to reduce the tidal volume. This is the protocol, so it was quite expected, and the plateau pressure was reduced as well, around 25 centimeters of water. They were even able to increase the peep with quite no impact on the PF ratio. And when the PCO2 increased a lot induced by the reduction of the tidal volume and the plateau pressure, when they put the extracorporeal carbon dioxide removal on, they were able to maintain the PCO2 in an acceptable range around between 40 and 50 millimeter of mercury, and to normalize the pH. And when you compare the bronchoalveolar lavage, all the inflammatory marker in the bronchoalveolar lavage before and after tidal volume reduction, you see that you see a significant reduction of all the inflammatory markers, showing that probably you may decrease the biotrauma, you may decrease the inflammation induced by your mechanical ventilation in the CKS patient when you reduce your plateau pressure. In another study, more recently, this is the study which was performed during the H1N1 pandemic. So it's a very homogeneous cohort of 123 patients who received ECMO. And when you compare survivors versus non-survivor, you see that the plateau pressure on the first day of ECMO was significantly lower in the survivors. So if we want to reduce the plateau pressure, we need to reduce the tidal volume. And we know that thanks to the efficiency, the good efficiency of the devices that we use actually, we are even able to do apneic ventilation. This is just to illustrate that even if you reduce a lot your tidal volume, reaching 0 milliliter of tidal volume, because the carboxylation is well assured by the devices, you will be able to maintain your PCO2 in an acceptable, in a safe range. So for reduction of the tidal volume, we have this study, a German study led by Thomas Bein, which is an extravent study. So they took 79 patients. They randomized these 79 patients with IRDS into two groups. One group, which might be called the control group, with classical ventilation with a tidal volume of 6 ml per kilogram ideal body weight, and the PEEP level was set according to the IRDSnet strategy. And on the other side, they use the experimental, in the experimental arm, they markedly reduce the tidal volume, reach until 3 milliliter per kilogram ideal body weight. They set the PEEP using exactly the same algorithm. And to compensate the low pH and the high PCO2, they had an echo. And the primary outcome was ventilator-free days at day 28 and ventilator-free days at day 60. And as you can see, for the primary outcome, this study was negative, meaning that they were not able to show any difference between the control group and the very, very low tidal volume group. but in that study they include a very large panel of ARDS patients. And if we focus on the sickest patient, meaning the subgroup with a PF ratio below 150, you see that clearly you see a potential benefit of using very low tidal volume in this sickest group with an increase of the ventilator-free days at day 28 and ventilator-free days at day 60 when you markedly reduce your tidal volume. So again, this is just secondary analysis. This is not the primary outcome. The study was not designed first to show this benefit on this subgroup. So it's a sub-analysis. We need to be very careful with the interpretation of the result. But it's quite a nice signal to say that probably in the sickest one, there might be a benefit to reduce the tidal volume. So if I reduce my plateau pressure by reducing my tidal volume, I will obviously I will cause pulmonary derecruitment, because the tidal volume will be so low that you will see some pulmonary derecruitment. So you need to play with the PEEP, and you need to increase your PEEP to try to balance this pulmonary derecruitment. And we don't have so much data about the role of the PEEP during ECMO. On ECMO, we have this study, which is a retrospective one, so it's always complicated to raise strong conclusion with this kind of studies. So this study compare what was the mechanical ventilation management in 3 high case volume centers. So 2 centers were in Australia and 1 was in Paris. You can see that the death in ICU in this very severe patient, this population was 180 patients. You see that the mortality rate was quite low, 29%. So if we compare this population in these 3 centers, you see that it's quite a usual panel of ARDS patient with 25% of influenza patient, the large proportion of bacterial pneumoniae, and you see that the interval between mechanical ventilation on ECMO was quite different between centers. In Australia, they go quite rapidly for ECMO, and in Paris, we wait a little bit of more time. And this is mainly explained by the rate of prone positioning, which was quite low in Australia. They didn't use so much prone positioning, and we tried to use prone positioning as much as we can in Paris before going for ECMO. But if we look at the ventilation parameters before getting on ECMO, you see that the patients were quite sick, with a PF ratio around 60. You see the PEEP level before getting on ECMO was quite high as well, with a PEEP level above 10. Tidal volume was conventionally managed around 6 milliliters per kilogram, and the plateau pressure was pushed at the maximum, reaching 32 centimeters of water. So if we compare what was mechanical ventilation management in 2 groups, in the ICU survivors and in patients who are going to die in ICU, you see that regarding plateau pressure, the plateau pressure was markedly decreased by after ECMO initiation, with no difference during ECMO between these 2 groups. But if we look at before ECMO, which is a well-known risk factors that was identified in previous works, you see that patients who are going to die in ICU had a significant higher plateau pressure before getting on ECMO. Regarding tidal volume, so ECMO initiation allowed to decrease the tidal volume, reaching between 3 and 4 milliliters per kilogram. And after day 7, because most of these patients were ventilated in pressure control, you see that the tidal volume increased, meaning that the compliance of the patient, compliance of the ICU survivors increased as well. But what was new and interesting in that work is that when you look at the PEEP level, if you compare the PEEP level before getting on ECMO, so the PEEP level was significantly higher in the ICU survivors, but the PEEP level was also higher on ECMO during the first 7 days in ICU survivors. So this is just univariate analysis. And if you do a multivariate analysis, you look at what are the independent risk factors associated with ICU deaths. You see that we have classical risk factors, which are duration between ICU admission on ECMO, plateau pressure before ECMO, and lactate at day 3. But what was new in that study is that there is maybe a protective wall of the PEEP during the first day on ECMO, meaning that a high PEEP level is probably a protective factor against ICU mortality. So again, this is retrospective study. We don't have so much data on that topic. So if I tell you to reduce your plateau pressure, to reduce your tidal volume, and then to increase your PEEP, at the end, what you do, you reduce your driving pressure. So the driving pressure is the difference between the plateau pressure and the PEEP. And I think all you guys have seen this landmark papers showing the direct relationship between the increase of the driving pressure and with the increase of the risk of mortality. And if you increase your PEEP, increase your plateau pressure in the same proportion, while keeping your driving pressure at the same level, you see that there is no impact on mortality. And ECMO just allow you to markedly decrease your driving pressure. So on ECMO, driving pressure should be one of your targets when you deal with mechanical ventilation. And to support that, we have this meta-analysis on individual patient data that we performed a couple of years ago with my colleagues Ari Sapaneto, showing that if you compare a patient who's going to die in ICU, so the patient in blue compared to the red patient survivors, you see that the driving pressure before but also on ECMO was significantly lower in ICU survivors. And if you look in a multivariate analysis, you look at what are the risk factors associated with ICU mortality. So you have the classical risk factors like time between mechanical ventilation on ECMO, but the only mechanical ventilation parameters that may impact on the outcome is the driving pressure. So the higher the driving pressure, probably the higher the risk of mortality on ECMO. And if we look again in this cohort of H1N1, you see also that survivors has a significant lower driving pressure at ECMO day 1. So when I told you to decrease your driving pressure, what is probably tricky is to know how far should I decrease it. And based on the work of Amato, you know this slide showing that if you are going under 15 or 14 centimeter water of driving pressure, you may probably have the greatest impact on mortality. So what we can say yet to date is that ECMO will help you to reduce the driving pressure, and probably on ECMO, targeting driving pressure above 15 centimeter water is probably not advocated on ECMO, and probably we should target to get a driving pressure below 15 or 14 centimeter water. So this was about the main component of the mechanical power, the tidal volume, and a second component is the respiratory rate. And ECMO allow you to markedly decrease the respiratory rate. We know that based on that sub-study of the lung safe study in a very large number of ARDS patients, showing that respiratory rate, total respiratory rate was an independent risk factor of mortality. So we know that with ECMO we can decrease this respiratory rate, and we have this quite clever study showing that if you took two populations, one population with a tidal volume around 355 ml, and you do exactly the same tidal volume for the other population. And if you compare these two populations, the only thing that you may change is the respiratory rate. You decrease by 2, you divide by 2 your respiratory rate. So in that group, which is called the ARDSNet group, you have 30 breaths per minute of respiratory rate, and in the interventional group, you decrease the respiratory rate while keeping exactly the same tidal volume. And to balance the effect of the low pH and the high PCO2, you had an echo to maintain your PCO2 at the exact same level compared to the control group. And so this is just the illustration of the protocol. So the only difference between these two groups is the respiratory rate. And then they compare the inflammatory markers in the plasma in the group where the respiratory rate was decreased, and they show that in the plasma you will see lower inflammatory mediators released in the circulation. But even if you look at in the bronchoalveolar lavage, you see that most of the inflammatory marker will be significantly reduced in that group ventilated with a lower respiratory rate. So definitely we need to reduce the respiratory rate to try to minimize what is called now the ergo trauma. On ECMO, most of the oxygenation will be achieved by the device. So mechanical ventilation is not so useful for providing oxygenation. So we need as soon as we can to reduce FiO2, because we know now the potential oxygen toxicity, and we know also that if you maintain your patient with 100 FiO2 with a low peep, you may see at the end denitrogenation at electasis, and we want to avoid that. So as soon as we can, if the saturation is well, you first decrease your FiO2 and while maintaining your FMO2, so the fraction on oxygen on the membrane at 100%. The last part is about myotrauma. We know that spontaneous ventilation is probably desirable, especially if you consider that this patient will be ventilated for weeks, even months for some of them, for the sickest one. So we know that you will see some diaphragmatic dysfunction induced by controlled ventilation, and you may see destructuration of the diaphragmatic myocyte very quickly after only 72 hours on controlled ventilation. You may see some ventilator-induced diaphragmatic dysfunction. So we need to try to work on preserving respiratory muscle function. And this is the ideal message, to say that you need to let your patient breathe spontaneously. But on the other hand, You need also to worry about the patient self-inflicted lung injury, which is now called the PCLI. And this is well illustrated in that case report, showing that when they put a patient on pressure support on ECMO, so it's quite easy to do because all the oxygenation and decarboxylation is achieved by the extracorporeal device. So what you need to look at is what is the transpulmonary pressure. And you see in that example that even if the tidal volume doesn't seem to be so high with pressure support, the peep level is not so high as well, the peak pressure is not so high as well. But if you look at the transpulmonary pressure, you see that you have a very large swing, large transpulmonary pressure, which may cause at the end a patient self-inflicted lung injury. So this is, you need to find the right balance between these two behaviors, and especially at the acute phase of the RDS, when the central drive is very intense for these severe patients. So if the patient is breathing too deeply, if he's not in synchronization with mechanical ventilation, then it's probably too early, and you need to resedate him in order to prevent for a patient self-inflicted lung injury. So what we use in my unit, we think that a PRV on ECMO will offer you to keep the control of the plateau pressure on the PEEP, because it's a pressure control mode. So you just set the high pressure and the low pressure. The high pressure is roughly the plateau pressure, and the low pressure is the PEEP. And then you will set your driving pressure. And the driving pressure, so the difference between the plateau pressure and the PEEP, will determine your tidal volume. And when you have set on the first day your driving pressure, you see that day after day, you see that the tidal volume generated by this driving pressure is increasing day by day, showing that the compliance of the patient is improving. And as soon as you reach 5 to 6 ml per kilogram ideal body weight of tidal volume, then it just tell you that the patient, you might probably try to do a winning test to win the ECMO. Another advantage of using a PRV in that setting is that you keep the control of the plateau pressure on the PEEP, but also you let a certain degree of freedom for your patient to have spontaneous breathing. And what is interesting in that mode compared to conventional PCV pressure control mode is that spontaneous breathing is not synchronized with pressure cycle, meaning that the patient will not receive an additional cycle as soon as he is doing spontaneous breathing. So this is what we use in our unit, and we don't have data to show you to say that it's much better than using a volume control mode or classical pressure control mode, but at least it seems to combine all these potential advantages. So actually, on mechanical ventilation on ECMO, what are the recommendations on expert opinion? What was used in the recent published randomized control trials? So if we look at the general guidelines for ECLS cases done by the EuroELSO, you see that what they say, they summarize what I already told you, that you need to decrease your plateau respiratory pressure below 25 centimeters. Try to get the lowest FiO2 that you can. And to prevent derecruitment, you need to increase your PEEP. And they give a very large panel of PEEP level between 5 to 15. So maybe around 10, it's probably a good compromise. In the recent randomized control trial, in the CSO trial, this is the strategy that was performed in the ECMO group. So they did quite the same. they decrease peak inspiratory pressure, trying to have a peak inspiratory pressure below 25. They maintain a level of PEEP between 10 to 15. They markedly reduce the respiratory rate. To see that they protocolize to do 10 breaths per minute respiratory rate and to decrease your FiO2 at 30%. And this is the extract from the recent EuroELSO trial. This is how the mechanical ventilation was managed in the ECMO group. So you see the FiO2 again was reduced. PEEP should be above 10 centimeter. Tidal volume should be decreased to achieve a plateau pressure less than 24 centimeter. This is if you choose to ventilate your patient with volume control mode. If you use a PRV, in the earlier trial, it was protocolized to use 24 centimeter water of high pressure level, and the low pressure level should be 10 centimeter of water, and by this way you have 14 centimeter of water driving pressure. Decrease your FiO2, and when we designed the earlier trial, we let quite a large range of respiratory rate between 10 to 30. So in introduction, I told you that we have so much to do in that field. It's something which is moving a lot. If you see the volume of publication recently done. So what's the future? Another way to markedly reduce the ventilator-induced lung injury might be to combine ECMO with proning, because you know this ProSEVA trial, which has shown a very strong impact of proning in IRDS after using long prone session, more than 16 hours. Showing a very strong impact on mortality. And we know that prone responders are not always the patient who's gonna survive. So even if the patient is not a prone responder, you may have strong impact on the proning, on mortality, probably because you reduce. It's one of the most efficient therapy intervention to decrease ventilator-induced lung injury. So to do that with VV ECMO, it seems at the beginning that you may think at the beginning that it's very difficult, but it's not so difficult. You just need to convince your team that is totally doable. And you have a couple of studies, small case series recently published. Most of them show that it was relatively safe to do that. And it might be benefit for probably the very hypoxemic patient, or probably in obese patient as well. And they show in this small series that for some patients, using prone position might help to decrease your FiO2 on the ventilator, but also on the ECMO machine, and to decrease your plateau pressure and improve your static compliance. So we don't have yet very strong data to demonstrate that there might be a benefit of using proning during ECMO, but it's definitely a new track that we need to follow in the future, and to try to investigate that by a randomized control trial. Another large area of research in the future in that field is to talk about individual titration of mechanical ventilation on ECMO. So you have probably seen many studies dealing with that. We try to individualize all our therapies in ICU. We try to individualize mechanical ventilation as well, and probably because we are dealing with a sickest patient, this population on ECMO might have a large benefit of having an individual titration, because you have a very large heterogeneity of the lung lesion, heterogeneity of the morphology of the patient. So it's probably quite utopic to say that we can apply the same recipe for everyone. So we are moving slowly, but we are moving a little bit to this strategy to try to individual titration for mechanical ventilation, especially for ECMO patients. And we have this study, very interesting one, dealing with not directly on ECMO, but before getting on ECMO. And this was a study published by the team of Marco Ranieri during the H1N1. At that time, mobile ECMO team were not so developed in Italy, so the patient potential candidate for ECMO were transferred to a regional center for ECMO. And when they arrived in that center, so 14 patients referred for ECMO consideration, they put esophageal pressure to determine what is the real transpulmonary pressure of the lung of this patient. So for half of this small population, they show that if you measure your transpulmonary pressure, for seven patients at 27 centimeter water transpulmonary pressure, which is the maximum that you can accept, that you can safely accept. So for this 7 patients, it means that you have pushed enough mechanical ventilation. You can't increase your PEEP. So probably these 7 patients are good candidates for getting on ECMO. But what is interesting is for the rest of the population, so the other 7 patients, when they look at the transpulmonary pressure of this patient, we got a very high plateau pressure, but if you look at the transpulmonary pressure, you see that your transpulmonary pressure, so the real pressure received inside your lung, is quite low, meaning that even if the plateau pressure is very high, probably because the patient is obese, because the patient has pleural effusion, there is not a good correlation between the plateau pressure and the transpulmonary pressure. And they show that for this patient, when you measure your transpulmonary pressure, thanks to the esophageal pressure, you show that the plateau pressure, transpulmonary pressure was quite low, so it allows you to increase the PEEP until reaching a transpulmonary pressure at 25 centimeter, which is the upper threshold limit. And then if you increase your PEEP, if you markedly increase your PEEP, you increase your oxygenation. So you decrease your oxygenation index, but increase the oxygenation of the patient. And then the 7 patients improved without getting on ECMO, just because you have personalized your mechanical ventilation. So in the context of ECMO, we have investigated with one of my colleagues, Guillaume Fonchino, we have investigated the use of EIT. So EIT is electrical impedance tomography. It's a bedside tool with a belt that you put around the thorax, which show you the distribution of the tidal volume during ventilation, and then you can follow what happened with an intervention. So for a small population on ECMO, we did a PEP trial, and with this device, you may obtain the percentage of lung collapse and the percentage of lung overdistension. And what you want to try to minimize both, so overdistension and the collapse. And probably the best PEEP level is the level when you have the lowest overdistension percentage and the lowest collapse percentage. And this is just illustrate in a representative patient. So we did a PEEP trial on this CV patient on ECMO, and as you see, as soon as I decrease the PEEP, I will increase the collapse, okay, reaching a very high level of collapse when I use a PEEP 0, and when the patient was ventilated with PEEP 20, the collapse was very low. On the other hand, at PEEP 20, if I look at the over-distension percentage, you see that roughly 50% of the lung is over-distended at PEEP 20. So this over-distension percentage decrease as soon as I decrease my PEEP level, and probably the best PEEP for that patient is PEEP 10, when you have the lowest collapse percentage and the lowest over-distension percentage. And this is illustrated visually. If you look at the screen inside, if you look at your screen, you see that all the blue parts represent over-distension, and the white part, the white color of the lung, represent the collapse zones. And you see that when I decrease my PEEP, I will see that all the blue area will disappear progressively. And if I decrease my PEEP too much, I will see some white areas showing that then your PEEP is too low and you generate collapse. So probably the best PEEP for that patient was PEEP 10. But what was interesting is to show the very large heterogeneity of the best PEEP between these 15 patients. Within these 15 patients, you see that it's very difficult to apply an arbitrary PEEP level, because you see that if you apply 15 centimeter water for everyone, for example, you see that some patients with 15 centimeter of PEEP have 35% of over-distension. And on the other hand, if I apply a too low PEEP for everyone, if I apply 5 centimeter water for everyone, you see that for some patients you may reach 60% of collapse. So it's very difficult if you don't monitor it to know what is the best PEEP for your patient. So we need tools at bedside to monitor what we are doing with this very sick patient. So as a conclusion, I will say that ECMO enables to markedly reduce mechanical ventilation. We all agree with that. And we are moving into a new paradigm when we will focus to reduce the tidal volume. To date, I can tell that the tidal volume should be reduced at least at 4 milliliters per kilogram, but no one knows if it's good to still decrease the tidal volume. Should we go until apneic ventilation? We don't have data to support that yet. We need to decrease the plateau pressure below 25 centimeter water. You need to decrease your respiratory rate, to decrease your FiO2 as well, with the same goal, which is to further reduce ventilator-induced lung injury. If you reduce your tidal volume, reduce your plateau pressure, you need to have a sufficient PEEP level to prevent lung de-recruitment. And after saying that, we have so many questions, and we need more studies to investigate different mechanical ventilation strategy on ECMO, and to determine if there is any clinical benefit to go further, to go until apneic ventilation, for example, to ventilate your patient only with PEEP, what is the exact PEEP role, and how to promote spontaneous breathing. And this might be tricky to control the central drive of this patient, which is very intense, especially at the early phase of ARDS. So we definitely need to monitor this patient, and we are working on that, and you may working on that as well, because it's such a large area that we need lots of research on that. Thank you very much.
Well, Matthieu, thank you so much for this very comprehensive, very clear presentation and interpretation of the available evidence that we have as of today with regard to mechanical ventilation and VV ECMO. There's lots of questions coming in, and I suggest and ask our participants to keep on asking questions so we can have a great discussion within the next, let's say, 15 to 20 minutes. Matthieu, I would like to take much of what you have presented and sort of transition that into the findings of the EOLIA trial, because I think many people will be discussing EOLIA right now, and what we found there is that this concept seems to be feasible. Many of the approaches you suggested and many of the data you showed within the last minutes just came up within the last very few years, much later than the EOLIA trial had been designed. But if we look at the way in the supplement of EOLIA how patients were ventilated, we could see that it is feasible, saying that minute ventilation went down from 12 to 4 liters in the treatment group of the EOLIA trial. There was a marked decrease in the tidal volumes. The P-plat, the mean P-plat was below 25, as you suggested in your presentation. The same applied for the delta, the driving pressure, which was less than 15. But with the respiratory rate, even in the treatment group of those on ECMO, which was above 20. Now, if we look at the equation that you showed on the mechanical power and ventilation, respiratory rate seems to be a target that we could work on in order to decrease the bad impact, so to say, that mechanical ventilation induces in these patients. What's your perspective if you put that into relation, what we have found in such a big trial and all those rather basic studies that came around? How could we further improve if you take that cohort?
Yes, so as you said, first of all, EOLIA showed that it was feasible. It was feasible, it was safe to ventilate this patient with a very low tidal volume and a decrease of the plateau pressure. What has been done in the EOLIA trial, Alain Combe, when he designed the study, let a very large large panel of the respiratory rate in the ECMO group. And probably because, as you know, this trial was designed 10 years ago. And 10 years ago, we didn't pay so much attention to the respiratory rate. So probably now with the development of all the system with echo, with this evolving paradigm to reduce mechanical ventilation after proving that it was quite safe, I think the next question is probably, should we go further? Should we still reduce the tidal volume much lower? Because it's totally doable to do that with such devices, which are very efficient for decarboxylation. You will never see any issue with decarboxylation on ECMO. So clearly we should is probably too early to say that, but we could decrease the respiratory rate much lower than it was done in the earlier trial. And probably for the tidal volume, we could also reduce it much lower, to go much lower. And some teams are defending that apneic ventilation might be useful. I don't have any opinion on that. I'm just waiting for data to show that it's safe, and then you need to be clear on what to do with your PEEP, because if you use apneic ventilation, probably you need to have a very high PEEP level, which may have also some deleterious effect.
This refers to one of the comments of our participants. One participant reports that in his experience, when he applies ultra-protective ventilation in a very severe RDS patient, he frequently sees total lung collapse. Is that something that you think we may be able to overcome with the PEEP, as you just said?
Probably, yeah, probably. Definitely, if you don't increase your PEEP enough, you will see a very large lung derecruitment. It's very oftenly it is seen during the first days, just after starting ECMO, when you decrease everything. But clearly, for most of our patients, have a peep above 10 centimeters of water. But again, using bedside tools might be very efficient to determine what is the best peep for these patients.
What do you use in your daily practice in order to account for that problem?
For we try to use bedside tools. Not so easy because the main question is money. Huh? It costs quite a lot to use EIT or to use esophageal pressure, but especially for the obese population, we try to use esophageal pressure, which might be useful to determine what is the best PEEP for this patient, because you know that all the numbers on your ventilator screen are not reliable at all when you deal with this severe obese patients. So esophageal pressure might be quite accessible, especially when you deal with the PEP settings. And EIT, we start to have a large experience with that tool. We have used it recently for proning patients and to try to determine which patients will respond to prone positioning on ECMO. But at that stage, to date, we are still on the research phase, and we didn't include that in our daily clinical practice.
Matthieu, you're touching the topic of the esophageal balloon, and we had a couple of questions on that from our audience. And I think we are lacking definitive data on that, on the efficacy of such measures. However, just a comment from my side. When we put ARDS patients to ECMO, or if we manage very severe ARDS patient without ECMO, we try nowadays as a standard to put in a balloon in order to avoid negative transpulmonary pressures at end expiration, which would mean that we are getting into a de-recruitment situation. So this is something that we do.
Yes.
The most questions we are receiving today are on the question of spontaneous breathing on ECMO, and I have the feeling that some participants would like to challenge you on your statement that it is desirable to allow for spontaneous breathing, and I have to say that you very differentiated discussed this topic and showed us all the data that we have. Now, my perspective is that when you have a severe ARDS patient, we have quite good evidence that proning these patients after the ProSaver trial, which you also showed, is probably a good thing to do. Now, when we look at this ProSaver trial, we always have to realize that the vast majority of those patients underwent neuromuscular blockage, and the mean number of days on NMBAs was five days in both groups, in the prone and in the supine group. So how can you find the right patient in whom it may be safe to breathe spontaneously the way that you said it could be done in the APRV mode?
Okay, so this is a good question, very challenging one. Clearly, I think it's totally utopic to say that you're gonna prone and let your patient breathe spontaneously at the same time. If you select to prone your patient, clearly all our patients are on neuromuscular blockers when we prone them, and we take the decision to prone them mainly based on the CT scan. For most of our patients, they will have a CT scan during the first 7 days. And actually what we do, the majority of our VV ECMO patients had at least one proning session, and during this proning session they will have neuromuscular blockers. If they are good responder, if they improve their compliance with proning, we will continue. If we don't see any effect, or even if the patient is the compliance is lower after proning than before, then we say that okay, this patient will not benefit for proning positioning. So then we will try to let him breathe spontaneously, but it doesn't mean that we remove the tube. It means that we just stop the sedation, try to decrease the sedation at the minimum, and see what happens with the patient in APRV. And what is great with APRV is that you still keep the control of the pressure. And but as soon as the patient is uncomfortable, if the spontaneous breathing is too intense, then you need to rapidly say that it's probably deleterious for the patient. So then you resedate him and retry on the next day, and so on, so on. So if the patient doesn't respond to proning, then we move to try to decrease the sedation level and to try to promote spontaneous breathing. But we don't do both at the same time.
Okay. Now, just kind of lost the question. Sorry for that. I just read you some questions that came from the audience, and there's two more questions on the APRV. I think we already touched that issue before on the PEEP. Two of our participants asked, how about the old APRV concept of having zero PEEP? What's the problem with that? And maybe you could explain that once more, because the questions came in pretty late after we had touched the PEEP issue already.
To do APRV without PEEP?
Yes.
Is it right?
Yes. I think so, this is again on the de-recruitment and all the problems for the opening practice.
Again, the question of the de-recruitment. And if with APRV, you mainly focus on your driving pressure. So if you use zero PEEP, which is, in my opinion, it's not desirable to use such a low PEEP level. But if you use very low PEEP, you will see a de-recruitment. And it also means that your high PEEP should be 14 or 15, which is very low for this patient. So we don't promote using zero PEEP, mainly because of the lung de-recruitment. So we promote to use high PEEP level, but to use low plateau pressure, and by this way, your driving pressure is always in the safely zone, meaning below 15 centimeters of water. If you deal with an obese patient, for example, probably you need to think a little bit differently, because you know that the plateau pressure is not a reliable determinant with this kind of patient. So probably for a very obese patient on ECMO, I will try to have a higher high pressure, so higher plateau pressure, maybe 26, 28. But on the same time, I will also increase my PEEP to maintain always this driving pressure below 15. So 14 is what we do in daily practice.
Okay. And we may want to mention that the Amato trial doesn't say that 14 or 15 is the threshold to being safe, but it could get even better if we go below, if you just the way you stated.
Sure.
So
sure.
I want to go back to the spontaneous breathing topic, and with respect to the respiratory drive that may harm patients in severe RDS. I understand literature the way that this high respiratory drive is caused by a central process of the patient, which interestingly cannot be overcome when you put a patient to ECMO. So even when you have a patient that is perfectly oxygenated, perfectly decarboxylated, patients with a very severe RDS still have that high central drive. And you mentioned that we could maybe control that. Now, if that was not the case with any level of sedation, would you know of any other concepts like a partial low level of neuromuscular blockers that could have an impact on the central drive in a beneficial way?
So I don't have this experience to use half dose of neuromuscular blockers to control the central drive. There are two major components of the central drive. One is PCO2, which is frequently normalized with ECMO. So it means when you have a high PCO2, you have a high central drive. Even if we think that we could control PCO2 with ECMO, for some patients, even if the PCO2 is still is normalized or even low, they have still a very intense central drive because we have some receptors in the bronchus which are sensible to the stretching of the bronchus, and that probably this receptor will command the central drive. So I don't have experience with half dose or quarter dose of neuromuscular blockers. As soon as we think that the central drive is too high, we sedate the patient.
Okay. So we are entering the final leg of this webinar and the discussion, and my final questions are concerning the topic of your winning strategy. If you have a patient that's awake, who's breathing spontaneously, and who's still on the ventilator and on ECMO, what's your winning strategy? Do you extubate them first, or do you try to get them off ECMO first? And if there's not a standard approach, how do you tackle the problem?
So this is clearly a good question, very clinical question. We don't have yet the answer. We have tried a couple of times to wean off mechanical ventilation before ECMO. And again, we have the same issue. The same issue is the control of the central drive. Some patients, we don't know exactly why, some patients will feel very dyspneic, even if the PCO2 is normalized. Because you need to play between the patient and the ECMO. So what we do in daily practice, actually, we think that considering the actual literature, we should probably win the ECMO first and then win the mechanical ventilation.
Okay. Matthieu, after this webinar, is there anything you would like to add as a remark, as a final remark to this session?
No, it was a pleasure to be with you. Clearly, we need studies. So if some of you are interested by doing studies in this area, there is so much to do that we need to explore all these questions. Should we win mechanical ventilation before ECMO? How do we win it? How to control the central drive? What's the key role of the PEEP? So we have so much things to explore that it's going to be exciting future years on that topic.
Matthieu, thank you so much for making yourself available in this great webinar. We really appreciated having you here today. And to our participants, if you came in late and you missed significant parts of this webinar, don't worry about it. It'll be recorded and put online, and you will be able to find it in the EuroELSO.net/education section, or just look for it by any search engine or on YouTube. Now, finally, I may announce the next webinar. That's going to take place on December 12th, again at 4 p.m. Central European Time, and it's going to be on unloading of the left ventricle in VA ECMO, and it's going to be hosted by our past president, Roberto Lorusso. So thank you again, all of you, for joining, and have a great day. Always make sure that your venous line is blueberry and your arterial line is cherry, then you're good. Take care.
Thank you,
Bye-bye.
Peter. Thank you very much. Bye-bye.
Bye.